Good afternoon, everybody from all around the world that are joining this first webinar of the i-Violin project. We have a great session today with three great speakers, which obviously I would like to thank for having accepting the invitation. We have Dr. Dimitris Kulik from the University Hospital of Ljubljana, Dr. Boris Biljatic from Zagreb, and Dr. Colin Martin that I will present in the future for each one of the presentations. We will we will have the three presentations delivered first, and then I will ask all the people attending to write down the questions, and we will have a question and answer sessions at the end of the three presentations. Now, this webinar is under the scope of the i-Violin project, especially the work package 7 that has to do with education and training on image quality evaluation tools and corresponding optimization. So we will have a series of 4 webinars, each of them with also other fantastic speakers, and the objective is to go through the concept of the i-Violin project. These are the members of the work package 7. So you have the University College of Dublin, the University Medical Center of Ljubljana, which we have the head of department today with us. We have the clinical Bonica Dubrava, which also we have Dr. Boris here today. It's from Queen Health School from Portugal, University of Crete, OVGU, the University of Marburg, University of Leuven, and a regulator from Finland, STUK. The objective of this work package is to develop an education training program for radiologists, radiographers, and medical physicists on how to implement optimization programs in CT procedures, including the use of image quality evaluation tools in view of reducing the exposure of oncological patients to ionizing radiation. So it's a huge objective that we have here in this project. And obviously, the education and training programs will be built through a multi-professional integrative approach with radiologists, radiographers, and medical physicists, as we've seen in several other projects, is the only way to get to the point that we need to increase the quality of the exam with obvious less exposure to the patient. This project and obviously this work package has been based on several outputs from several other EU projects. We then have several other aims that I will not go through them all, but through the end of this project, that will happen in this year, in month 8, in August, we are sure that we will achieve all these specific aims. So these are our 4 webinars. The first one is being held today. Please, you can scan this QR code if you have not yet registered for all the other 3 webinars. So the next one will be next week, in fact, in 1 week. The other one in April after Easter, and the other one on the 16th. And all of them have all of them together at the end will fulfill the objectives of this work package. So for the webinar today, we have 3 main learning outcomes, which is to understand the justification process, the roles and responsibilities, to learn about the common methodology and tools used to apply and audit justification of CT examinations, and to know how to manage accidental and unintentional CT exposures. So this is what we will be discussing in the next almost 2 hours. So a warm, obviously, thank you to all the partners under the work package 7 members, and obviously most important is a warm thank you to our speakers today. So the first speaker we have today, as I said, let me check here I will try. Dr. Dimitris, please, can you put your camera on? Yes, we have Dr. Dimitris online. Dr. Dimitris, as I said, is a radiologist is head of department of the University of Ljubljana, very well known, and more important than that, he's a very good friend. So Dimitris, thank you so much. The floor is yours. Let's see if we can share your screen. Perfect.
You can hear me probably loud and clear. Thank you.
Loud and clear.
Thank you, Graziano, for the introduction. Today, I will say a few words about how to implement justification of medical imaging into clinical practice. This is outline of my presentation. There are quite a few things I would like to pass to you. And the importance of the entry data results in a good report. So if we have poor input data, the report cannot be really good. And what we should never forget, we should treat the patient, not the images. And justification and optimization of medical imaging is a basic requirement of radiological protection, and majority of EU member states have adequate legal solutions. However, they are not always implemented in practice well. So this could be especially problematic in complex patients. There are referral guidelines that are helpful for referral doctors. However, radiological justification is of utmost importance in safe patients management, especially for those patients which are the most complex. What's the role of diagnostic imaging? Imaging and clinical reporting should be that it influences patients' management. So basically, it could confirm or reject different diagnoses that are put on as a question. And more important than that, imaging and clinical reporting should answer clinical questions. If we are talking about the legislation in Slovenia, we have regulation about the use of ionizing radiation in medicine and intentional non-medical use. It was updated in 2018, and it prepares a framework, legal framework for medical imaging. Any radiological procedure in Slovenia can be performed only if it's prescribed by referring physician and if it's confirmed by performing physician. And the later performing physician is also responsible for the procedure itself and has clinical responsibility for the procedure. What it means, we should not allow any procedure if we think it's not indicated. Any radiological procedure should be indicated, so it means the patient should have need of this procedure, and it should be optimized by ALARA principle. Why is it important? There is a dose burden of different radiological procedures that's very different. If we are talking about the chest X-ray, it's 3 to 10 days of natural background. In lumbar spine X-ray, we are talking about 5 to 6 months. And in contrast bowel imaging, which are rare, however, still performed and not changed by other methods, we are talking about years of natural background. In CT, the doses are even higher. Head CT is approximately 100 chest X-rays. However, abdominal pelvic CT is even higher, about 500 chest X-ray. And majority of CT examinations have have quite high doses. On the other hand, if we are talking about chest CT, which is made for screening, there we are very, very in line with chest X-rays. Of course, there are quite considerable doses also in nuclear medicine, and PET-CT, which is a combined procedure or investigation, has a dose of about 400 chest X-rays. Why is it important? There is an old study that presumed that one little cancer due to irradiation is after 2,000 abdominal CTs. In my institution, yearly, we performed about 30 to 40,000 CT examinations, and probably about 10,000 of these are abdominal CTs. So for some little cancer are responsible also radiologists. Also, the modern technology can provide higher doses as older technology, so we should really take care of the doses. Justification for any diagnostic or therapeutic procedure has to be done on basis of the cost benefit. What it means? Potential damage to the patient has to be lower than expected benefit. And procedures or imaging should be performed only if it would influence the course of the treatment of the patient. What is damage? Any unnecessary examination or procedure extends course of the treatment, and we can even find incidental findings, and we can get to the wrong conclusion. Additional phase on CT makes additional irradiation. Many examinations with ionizing radiations can be switched to those without, let's say, ultrasound and MR. And of course, applying a contrast media can result in allergy, in renal impairment, even in MR application of contrast media can result in NSF or even gadolinium brain deposit. So damage, we have to calculate that when we are deciding about the examination. No diagnostic method or procedure is a substitute for anamnesis or clinical examination. Patient with right abdominal pain that is sent to radiological department for abdominal ultrasound or CT, after the patient takes off clothes, we see that he has a scar after cholecystectomy, and the patient himself confirms that he had cholecystectomy. So here the indication was really not a right one. Who should do referral to radiological department? It should be done by the doctors. Why? Because they are the only ones who can provide adequate clinical data. We have classical paper or e-referral to the radiological departments, and for that we should have the right IT solution. The patient can be ambulatory or hospitalized. If the patient is hospitalized, that's much easier to get the data from referring physician, and we have much easier access to medical documentation. In ambulatory patients, many times it's really difficult to access data, especially in countries that don't have integrated IT solutions. What should be written on the referral? We should know for which patient, which examination is required, who is the referring physician and the referring ward, because there we can get additional data. There should be diagnosis, but even more important than that, clinical questions or clinical dilemma, which should be answered by the imaging. And of course, we need additional clinical data about renal function, about diabetes, about coagulation status, if the patient is sent for interventional procedure. For the most complex cases, we have multidisciplinary meetings, and in my department, we have more than 10 each week. There is a debate between radiologists and referring physician, and the aim of this meetings is to find the right examination and right procedure for individual patient based on clinical evaluation and clinical conditions of the patient itself. There are some radiological procedure that bear the high irradiation burden on the patients. Mostly CT with high doses in pediatric and radiology and mammography. There are sensitive organs and sensitive tissues, and interventional radiology and interventional cardiology, there are long-lasting procedures with high doses. Diagnostic reference levels are good because they are indicating expected radiation dose received by a patient undergoing a certain imaging procedures. Levels, however, are based on population statistic, standard patient and most common examination. Population statistic, as you all know, is based on Gauss curve. The problem is there is no impact of the technology we are using, no influence of human factor, and no influence of different pathology. If you are doing CT abdomen, liver can be scanned differently than retroperitoneal changes, than pancreas, and this is not such thing is comprised in diagnostic reference level. The most common examination, let's say chest CT, there is no difference between different pathology. If we are doing chest CT for pulmonary embolism, for lung parenchyma, for ascending aorta with ECG gating, there is no such information in DRL. However, the doses and the protocols may be very, very different. Diagnostic reference levels are made to standardized, especially frequent examination. However, the rarer ones and those with high irradiation burden should be adapted to patient needs and clinical requirements. In diabetic and obese and elderly patients, if we are doing CTA for peripheral arteries, they have calcified arteries many times. So double energy CTA is done for better evaluation of the patient. In that case, we get similar image quality as in younger teen patients. However, larger dose of ionizing radiation is needed. The problem with the CT is that the number of radiological examinations worldwide is increasing. And in my center, we have 5 to 10% increase of CT examination each year. And years ago, we did a study, and more than 60% of ionizing radiation on patients in Slovenia comes from CT. So population radiation on population is increasing each year. In pediatric radiology, we have special pediatric diagnostic reference levels. They are made mostly for CT and for X-ray examinations, and they are based on weight and also on patient age. Why? because head in newborns is much larger comparing to the weight as in a bigger child. And protocols, of course, should be adapted to clinical question, not really to the region we are examining. Mammography should always be a combination of clinical data, of anamnesis, of family history, and additional imaging methods like ultrasound and MR. For mammography, we have to have digital, high technological machines. We need special monitors and special reading condition. And since mammography is one of the most common screenings, optimization and auditing is of utmost importance there. In interventional radiology, we have many factors influencing the method or what we will do during the procedure. Mostly, we were happy that digital machines will reduce doses. However, it's not always true. We did study years ago with patients with EVER, and we checked 172 of our patients, and 2 grays were exceeded in approximately 2.3% of the patients. And then we got new digital machine, and we collected the data for the first 6 months. And in the same procedure, EVER, 3 grays were exceeded in quarter of the patient, and maximal dose was more than 6 grays in 2 patients. And it took us a long time to optimize. It was a teamwork of radiologists, medical physicists, radiographers, and also authorized applicator from machine vendor to equalize the dose with the old analog machine. Dose tracking is very good. There are now many programs that are allowing dose tracking. So we gather data from all the machines and we set alarms for the outliers. And when we got these outliers, we should determine the cause, what caused the higher dose. It can be machine failure. If it's so, this machine should not be used. Many patients are getting overweight, so there we will have higher doses in future. Many times the complications or complexity of the procedure are the cause of the higher dose, and also sometimes human errors. And in these cases, we should educate this staff. A few words about referral guidelines. They are made mostly for referring doctors, and before referring patient to radiology, they should know, did the patient have had such examination yet? Does he need it and when? Has he chose the right examination? And the most important, will it have clinical impact? If the therapy will not be changed with the report of the examination, then probably this patient does not need such examination. There are many societies that have different guidelines, British, European, American, Canadian. And I will show you a few examinations, the few referral guidelines that are not really good or up to date. In acute thoracic pain and in patient with suspected aortic dissection, these are American older guidelines. They, with the rating 9, so the highest rating, they suggest chest X-ray. Chest X-ray is, in my opinion, and I'm dealing with vascular pathology for more than 25 years, it's not useful in determining aortic dissection. CTA with contrast media and, of course, adding abdomen since now we have possibility to treat it endovascularly, of course, is a better method. Dose is much, much higher. However, with such examination, we get all the data necessary to treat the patient. In acute diffuse abdominal pain, Americans, they have three groups of patients. One is patient after operation with raised body temperature. Another is with raised body temperature, but without operation. And the third case is pregnant patient. In a patient after operation and high fever, they would start with CT, and with or without contrast media, and ultrasound is only at the third course. And by American suggestions, it only may be appropriate. It's similar with the patient with raised fever and no recent operation. And only in a pregnant patient, ultrasound of the abdomen is the first investigative method. I think in most of the European countries, ultrasound of the abdomen would be the first method we would perform in such a patient. Experience also is very important, especially in high dose examinations or in pathology where specific tissues and organs might be damaged. In my hospital, majority of pediatric interventional radiological procedure are performed by a single most experienced interventional radiology. And similar is when we are treating pediatric patients on CT. A few words about emergency examinations. Emergency examination many times have higher doses. The problem is that these are emergent situations. Many times radiographers and radiologists are less experienced, and many times they are not so familiar with certain examinations. Also, the stress plays a major role in not saving the dose as much as they would in normal conditions. I will give you now a few clinical examples. Since we are dealing mostly with CT, I would like to present a few cases when justification optimization is very, very important. In patient number 1, we have a clinical data of the patient with the back pain, especially during movements. That's what was referred to radiology. We did not get any data of anamnesis. What is the cause of the pain? The patient fall from a height. He had head and thorax laceration, however, no visible marks on abdomen. And we decided to perform CTA. And on the CTA, we could see there was a vertebral fracture and there was aortic laceration. If this patient would come without anamnesis of fall from the height, the protocol would be completely different. This is another patient with thoracic pain after traffic injury, and native CT was done, and aortic hematoma is seen with also some fluid in pleural space. Should we extend the procedure with application of contrast media and increase the dose? Of course we should. We should do CTA of head, neck, thorax, and abdomen, practically whole body CT, because the trauma mechanism was such that it lacerated aorta. So it means that the trauma forces were really high. And here the added burden of radiation is really not important, because we have to see what's going on with the patient. In the third patient, sometimes clinical signs of aortic pathology and pulmonary embolism are present in the same time. So in a new scanner, we would apply 80 milliliters of contrast media. We would do a single phase CT, and perhaps we would do also ECG gating. In this scan, you can also depict very often coronary arteries, which might be also cause of similar problems. Instead, if only aortic pathology is suspected, we can do single phase CT with much less contrast media. In another patient with peripheral arterial disease, we have to know if it is critical limb ischemia or claudication. In patients with critical limb ischemia, this is limb and life-threatening condition. CTA, single phase, and 60 milliliters of contrast media are enough. In claudicants with the claudication more than 500 meters, we don't need any imaging investigation because the complications might exceed the benefits of the investigation. On the other hand, if we are dealing with the sportsmen, young, very active patients, then in this we should do also CTA because the stenosis or occlusions impact their life considerably. And the pathology can arise from aorta, iliac, or distal arteries, so abdominal aorta should be depicted also. CTA of a single phase of aorta and peripheral arteries should be performed. However, if you have diabetic patient, double energy for below the knees arteries should be performed because we are expecting calcification. And here we will raise the dose intentionally because we want to have a good clinical outcome. Aortic aneurysm treated with stent graft, there we need additional venous phase to exclude EVAR failure. In asymmetric flow, due to a single limb pathology, additional below the knee phase will allow us adequate filling of diseased arteries on a single limb. In patients with severe abdominal pain and hemodynamic instability, whole abdomen in 2 phases is planned. However, when we see rupture of abdominal aorta already in arterial phase, we can skip the venous phase because we have gathered all the data required. And in the last patient, there is a patient with single 4 centimeter lesion in left liver lobe, and this patient was referred for abdominal CTA to exclude malignancy. We changed that. We did contrast enhanced ultrasound of the liver. We confirmed focal nodular hyperplasia, and no additional imaging or investigation was needed, and no irradiation for the patient was necessary. And in conclusion, I have to say that modern medicine is based on medical images. There is no good hospital without good imaging department. Technical evolution resulted in powerful machines, and they give us a lot of information. However, we should think about the irradiation burden and justification and optimization of radiological procedures should be a daily routine, and they should be based on patients' needs and requirements. So thank you very much, and salutations from Ljubljana. If you have any questions, I will answer them later. We will have another presentation after mine. So thank you, Graziano, and back to you.
Thank you, Dimitri, for this outstanding presentation. And thank you also for joining us for the end of the session for the Q&A. We already have questions from the audience, and I will encourage the audience to write down, please, your questions on the Q&A. Now we go immediately for our second speaker. Our second speaker is Dr. Boris Vilacek from Zagreb. And Professor Boris is the past president of the European Society of Radiology and is actually chair of the Eurosafe Imaging. And because of that, I have the real privilege to be working very closely with him. And he is the chair of Department of Radiology in the University Hospital Dubrava in Zagreb. I hope I'm saying this Croatian words correctly, Boris. And thank you so much for joining. And the floor is yours, Boris. Thank you.
Thank you very much. Graziano, I hope that you hear me well.
Perfect, loud and clear. And we have the slides also.
Thank you. So I'm going to speak about results of the audit of CT referrals in 7 EU member states. This is about the process of justification in imaging and European projects. And this is a major European project that is finalizing by the end of this month, that was performed in 7 EU member states. It is called European Coordinated Action on Improving Justification of Computed Tomography, or EU Just CT. So this is the tender that European Commission opened several years ago and that European Society of Radiology applied for. It was, I have to say, very complex. It lasted 3 years, started in April 2021. And will last until the end of this month. So it is now in the final phase. We have all results and they will soon be published. This project aims to improve justification of computed tomography in Europe through coordinated action. And specific objectives are 4. First was to collect up-to-date information about justification of CT examinations in Europe, which was done and published in Insights into Imaging. First author of this was Shane Foley. It took some time to collect those information. Then we were developing a common methodology for auditing justification of CT examinations with the purpose that this methodology can then be used in other countries. And we already have some intentions in some European countries to use this methodology. Then we were supposed to carry out coordinated pilot audits of justification of CT examinations. And then the 4th objective was to discuss the status of justification of CT examinations with the member states and to identify opportunities for further action. As we have heard already in a previous lecture by Dimitri Kuhel, individual justification of CT examinations is a process through which it is ensured that the patient undergoes the appropriate examination in accordance with the clinical indications and the reason for the examination specified on the referral clinical question that was clearly shown in a previous session. If the CT examination requested is not appropriate according to the clinical indications and the reason for the examination specified on the referral, then it is considered to be inappropriate or not justified. The process of justification is implemented when the referral is reviewed by a radiological practitioner. And this is so in all European member states legislation by Basic Safety Standards Directive that was basically taken into national laws since 2013. The radiological practitioner then decides whether the requested examination on the referral is the appropriate one, or whether this requested examination should be changed into a more appropriate examination, or whether it should be completely refused. If the clinical indications and the reason for the examination are absent from the referral or insufficient, then it is impossible for the radiologist to evaluate the appropriateness of the requested CT examination, and in this case, the requested CT examination cannot be justified. Unfortunately, this is not uncommon. There are quite many referrals, as you will see soon, that with practically no clinical data or insufficient clinical data to even evaluate whether they are appropriate or not. Now, there were already some mentioning of different clinical decision support systems or imaging referral guidelines. And basically, European Society of Radiology worked very long on creating proper imaging referral guidelines that are embedded in IT systems, in basically workflow, in electronic hospital records workflow, so that referrers can actually write all the needed data and send this referral to radiology. It took a long time in cooperation with American College of Radiology that had this appropriateness criteria that Dimitri has shown in a previous lecture, and basically ESR Europeanized ACR's original methodology as far as applicable and has established additional methodological guidance for its experts, establishing several key principles. First, it is updated annually, and then it changes to existing recommendations, and any additional guidelines should be based on evidence as far as possible. So subspecialty groups review new published data and modify previous guidelines. So the expert opinion, judgment, European practice standards should only function as a supplement when necessary, and appropriateness recommendations should give no consideration to national or institutional circumstances, costs, or availability of equipment. So this i-Guide system that has more than 2,300 clinical scenarios was used also in this European project that I'm speaking about. So this system can be embedded as clinical decision support system into IT workflow in hospitals. So it is basically at the point of care, embedded at the point of care, not just guidelines on the paper. And for instance, if you have a question of, let's say, 23-year-old male, you put in age and sex and put clinical indications like ataxia, slowly progressive or long duration, and then you automatically get several options of MRI head without or with IV contrast as being most appropriate. Apparently CT here has this yellow mark, so there is a range from 1 to 9. Usually 1 to 3 are inappropriate or mostly not appropriate examinations. 4 to 6 points are moderately appropriate. Usually there are more appropriate, like in this case, if they requested CT, the feedback for the referrer would be that MR is more appropriate, and then from 7 to 9 are appropriate examinations. Basically, or for instance, this clinical question in 6-year-old girl who had right lower quadrant pain, possibly appendicitis. Apparently CT is not appropriate here. Ultrasound of abdomen is most appropriate clinical examination, and then CT has less favorable appropriateness score with IV contrast. So this i-Guide system was used as a standard methodology to assess whether the referrals were appropriate or not. 7 countries were contracted in this project: Belgium, Denmark, Estonia, Finland, Greece, Hungary, and Slovenia. So geographic spread in EU was very good, including Scandinavian countries, including Central European countries and Southern and Eastern European countries, and in two small countries like Estonia and Slovenia, whole country was sampled, all units, imaging units that performed CT in a specific 1 or 2 work days, and in other countries, other 5 countries, specific region was sampled, with the planned sampling of 1,000 cases per country. So the cases were collected in 1 or 2 consecutive days in cooperation with national competent authorities and radiological societies of particular countries. There was no selection bias, and statistics methodology was based on what Israel Central Bureau of Statistics and Professor David Pfefferman performed. Prepared. So national competent authorities were contacted. 4 auditors per country were doing audits, and instructions on the use of iGuide were provided by European Society of Radiology experts to these auditors. Auditors were not from the same hospitals or regions where referrals were audited, so they were always from different parts of countries or different regions, and they were selected by national radiology societies. Collecting anonymized cases were representing audited country or region, and we were looking at differences between public versus private institutions, inpatient referrals versus outpatient referrals, and many other items. There were some problems in auditing process. Auditors were working in different phases. Some auditors dropped out. There were needs to substitute some auditors. It was quite cumbersome and long procedure because they had to do roughly 500 cases each and compare it with iGuide. There was supposed to be translations into English from national languages because most were originally in local language. None of the countries had English as a primary language, and special thanks has to go to the ESR office to huge work that was performed in this project. Steps in analysis were different, were multiple. First, it needed to be, the data needed to be validated. Then the combined data set was created. Cleaning data step was performed by statisticians, several very experienced statisticians that were already involved into some iGuide related publications. And then there was arbitration step. Whenever disagreement was found between 2 auditors, then arbitration was performed to get a final iGuide points, so to say. Then there was creation of data set for analysis, including definition of dependent and explanatory variables to be able to perform testing of statistical significance of differences. Descriptive statistics was performed, and then in-depth statistical analysis. So, for instance, reasons for exam or clinical indications missing or not specified are presented here in several of these referrals, where sometimes we knew what the referrer specialty was, sometimes it was unknown, so this was also analyzed. As you see here, patient sex and age, and whether the patient was outpatient or inpatient, but in these cases, there were practically no data or not specified data in referrals, and you will see later on the statistics of how many examinations were performed, because it was retrograde analysis, actually with no clinical data or insufficient clinical data. Then there were some cases where exams couldn't be properly defined, usually due to lack or no existence of clinical data, where reasons for indication were unclear or incomplete or not specified. And then there were some reasons where the exams couldn't be properly defined because not enough data or incomplete data, as I said already. Examples where there were no proper indications in i-Guide and where arbitration was supposed to be done were COVID cases. This is now being upgraded in a new version of i-Guides. We had one country, specifically Hungary, with almost 14% of referrals in COVID patients that were mostly considered appropriate, although this is clinically sometimes questionable, but some countries had very few COVID cases. One country had quite big because it was sampled just in the wave of COVID pandemic in that particular country. Then there were some oncologic follow-up things like mesothelioma or whole body scanning and lung carcinoma. As I said, lack of clinical information when there was only headache without whether it was chronic versus acute, with or without neurological problems, we wouldn't know, and based solely on referral and not on patient's clinical record. The arbitration was performed, as I said, ESR i-Guide defines values of 1 to 3 as inappropriate, 4 to 6 as moderately appropriate, and 7 to 9 as appropriate, and we use these definitions instead of score itself. When no match was found, a score of 0 was assigned, and we accepted scores between 7 and 9 as being in agreement, and 4 and 6 between 4 and 6 in agreement. But if one auditor flagged score as 6 and the other one as 7, so other group, this was called partial disagreement, and then we did arbitration. When scores were judged to be in agreement, no further action was required. So where scores were judged to be in partial or serious disagreement, for instance, one arbiter would give 2 points and the other one 8, a third auditor's opinion was required. This was described in original methodology, by the way, which was taken from 2 previous national audits in Luxembourg and Northern Ireland, and there was only or cases when there was only one score. If there was no score at all, there was no score by both auditors, arbitration was not done. In other cases where we had double records, it became apparent that some referrals had been included twice in the data under different or even same referral ID numbers, and then they were marked and appropriateness score was considered only once. So it was quite cumbersome, and you see here an example on the first 3 columns between auditor 1 and auditor 2, where there were differences and arbitration was performed, what were the final scores. Also, we were looking at referrer specialties. For instance, here we had to decide whether there was, for instance, internal medicine or surgery arbiter, or family medicine or public healthcare medicine. So we had to basically, in some cases, look more into files to perform arbitration. Now to look at the most important data, these were our 7 countries, where, as I said, entire countries were audited in Slovenia and Estonia, while certain regions in Belgium, Denmark, Finland, Greece, and Hungary. And basically we had, as you see here, mostly in some countries only public centers. In some countries there were actually only in one country, in Greece, the majority of centers were private. In other countries, majority of centers were public or exclusively public, like in the case of Hungary. For instance, this is what you see in Finland. Helsinki district had 2 hospitals, but one huge hospital, public hospital, had 16 different sites where they were performing CT examinations, and so basically 16 were public and one site was private, but those 16 were under the one roof, so to say. And the same thing is also in Hungary. There were 4 big hospitals, but 21 centers. And if we look at the we have CTs per country performed per year and estimated CTs per day. And basically, we collected in the end, and this is the most important table, more than 6,700 CT referrals, of which 202 were removed from analysis because of duplicates or invalid data, and 633 were unscored due to no or insufficient clinical data. So this third row is very important because you see that referrals with no or insufficient clinical data were very few in Denmark, less than 2%, in Belgium 1%, in Finland almost none, only 0.3%. However, they were very large share of referrals with no or insufficient clinical data were in Slovenia and Greece, over 20%, more than 8% in Hungary, and more than 5% in Estonia. So these are actually referrals or CT examinations that were performed. We couldn't determine whether it was really appropriate or not based on documentation. Probably some were appropriate, some not, but this couldn't be scored. Of which referrals that could be scored were 5,899, 91% of referrals in Denmark, 73% in Slovenia, 93% in Estonia, 97% almost in Belgium, 73% in Greece, almost 90% in Hungary, and 97% in Finland. Now, these are the data of fully appropriate scores, but this is only from scored referrals. So these are not referrals that had no or insufficient clinical data. We see that fully appropriate scores among those that were scored are the best in Denmark, over 85%, almost 80% in Finland, Slovenia, and Belgium, 75% in Hungary, 68% in Estonia, and 58% in Greece. But as I said, Slovenia and Greece had a lot of referrals that couldn't be scored. And then partially appropriate, as you see here, were from 10% in Denmark to 26% or 26.5% in Greece, and totally inappropriate from 3.6% in Denmark to 15.6% in Greece. This is the different way that these results are presented in bars. And then we were looking at institution type and country, public versus private, as you can see in most countries. So in Hungary, we couldn't look at this. In Finland, there were only 11 referrals in private, so very few. In all other countries, and in Denmark, there were only 9 in private. So in all countries where it could be done, it was clear that appropriateness rates were higher in public institutions as compared to private. Also by patient status, whether patients are inpatients or outpatients, statistically significant difference were much higher in inpatient. Looking at gender, there were some differences between female and male that were statistically significant in 2 countries. We don't know yet why, but we need to see more in this data. And the other thing which we have seen here were that there were very few examinations in children performed overall, with appropriateness rates mostly higher in children, with exception in 1 country, but because of very low numbers, this is not really good for the analysis. Regarding referrer specialty, if we look family generals to specialist doctors, we didn't have data in Finland, and in Hungary, all these family doctors were actually residents in emergency medicine, so data there are also not reliable. Basically, there where they are reliable, we see that the doctors who were specialists had better appropriateness rates. Then we were looking at differences between different surgical specialties, emergency medicine, family medicine, and neurologists or brain-related specialists in different countries. These data will be published extensively, and you see here these graphs. We don't have time to go too much into it, but you will see conclusions later on. And we looked also at more appropriate exam. In cases when another exam was recommended as more appropriate, it was mostly MRI in most countries, or in Finland, other CT, or even 2 exams, or in Greece, other X-ray. So as a summary and conclusions, we have seen very low numbers of pediatric CT examinations in all countries, in the range of 5 to 27 examinations per country. So this is minimal, only 1% of the whole number. And basically, pediatric radiologists in Europe seem to be increasingly aware that the preferred modalities for pediatric imaging examinations are ultrasound and MRI rather than CT and X-ray. And basically, we discussed this in the working group for pediatric imaging in Eurostate. Appropriate, if we look at difference in justification rates between general practitioners and other specialist doctors, appropriateness rates were statistically significantly lower for general practitioners, as I said, compared to other specialists in Belgium, Denmark, and Slovenia. In Greece, they also had lower appropriateness rates, but there were only 20 referrals from general practitioners. And basically, this reflects the situation that specialist doctors in Europe are better educated in their specific specialty fields to refer patients for the specific imaging modalities as compared to general practitioners, because general practitioners need to deal with a wide spectrum of diseases and clinical situations. This appears logical, and this was also observed in previous audit projects. Differences in appropriateness rates between body regions were observed in 6 countries, all except Finland, where spine had quite low appropriateness rates, followed by extremities and pelvis. In Finland, interestingly, the lowest appropriateness rate was observed in polytrauma whole body CT, but they have altogether quite good appropriateness rates and do much more MRI than other countries. These results are comparable to the audit study in Luxembourg, where the appropriateness rate for the spinal area was very low, only 28% for the lumbar spine, as well as for the extremities, with an appropriateness rate of only 50% for lower extremities. Then, if we look at public and private facilities, in most countries, the balance was considerably on the side of public institutions, with exception of Greece, which had 2/3 of private. In Hungary, all audited facilities were public. In Belgium, public and formerly private hospitals have the same model of administrative and financial management and same justification rules and patterns. Same rules and patterns, but better appropriateness rates were observed in public system, also in Belgium, like in other countries. And then Finland and Denmark had only very small proportion of private centers, which performed very low number of examinations. So the differences there haven't reached statistical significance. So in Slovenia, Belgium, Greece, and Estonia, statistically significant difference was demonstrated in the appropriateness scores between public and private centers, and the appropriateness rates were significantly higher in public institutions. According to the survey of the centers that were planned to be audited, MRI was available in almost 3/4 of facilities, and in most countries, the most appropriate examination in cases where CT was inappropriate was MRI, so access to MRI is important. Basically, based on the survey responses referred from centers to be audited before the project started, actually countries with highest percentages of departments that apply quality assurance and written procedures were in Denmark, Belgium, and Finland, where the results were the best. So correlation apparently exists between the availability of written procedures for justification and appropriateness. For all countries, as I said, appropriateness rate for CT was better for inpatient than for outpatient care. This is logical. Emergency care physicians are well trained, and the likelihood for ambulatory care patients is higher that they are referred to inappropriate CT examinations if referrals are made by non-specialized doctors. Finally, we have to conclude that conducting and running such a coordinated justification project, which was the first ever in 7 countries parallelly in 7 EU member states, requires a huge teamwork between European Society of Radiology, national radiology competent authorities, project leaders, auditors, and statistical analysis team. There were and are many practical questions that need to be answered and addressed, and we believe that the results presented raise important issues that could be used by European Commission for guiding the proper use of CT across Europe. Part of the project was to write the guidance document that will be available to all national authorities and radiology departments in European Union once when the project is finalized and when the final results, which is around 150 pages, will be published in Radiation Protection Series of European Commission. So this was shortly about this huge project, and I hope that it wasn't too long. Thank you very much for
Thank you, Boris, for this outstanding overview of the EU Just CT. I think I think that the audience saw a very interesting project and how to implement it as well. So yes, I will kindly ask you to stop sharing the screen, and we'll go to our last but not least speaker of this webinar is Dr. Colin Martin. He's very well known from all around the world. Colin, it's a really pleasure to have you with us here. Dr. Colin Martin is Vice Chair of ICRP Committee 3, Protection in Medicine, and an honorary senior lecturer at the University of Glasgow. And he worked as a medical physicist over the last, I don't know, more than 30 years, and he has contributed significantly for the let's say, to improve this radiation protection safety culture all around the world. Colin, thank you so much. The floor is yours. It's a privilege to have you with us. Thank you.
Oh, thank you. And I must say, I was impressed by the results from Boris's presentation. That's going to be an very important study for the future. So I'm going to talk about management of accidental and unintentional exposures. So I'm not going to stick entirely to CT. I'll also talk about other radiology exposures, but I'll stick to radiology and say, but I'll include interventional radiology. So I'll go through, first of all, the definitions of an incident, an accident, talk about the investigations into causes, talk about the methodology for incident prevention, assessment of doses, then talk about interventional and CT incidents that do or can cause injury to the skin, the methodologies for minimizing these injuries, and then very briefly about unintended fetal exposures. So an accident is an unintended event caused by errors and various things, but the consequences or potential consequences of which are not negligible from the point of view of safety. Whereas an incident includes the same range of errors and equipment failures, but it will also include initiating events, accident precursors and near misses or unauthorized acts, and also include things which haven't resulted in consequences because they've been caught at an early stage. But it's important to analyze these as well. In the IAEA Basic Safety Standard, there are various definitions of the different types of procedures. There's the error, which is the wrong individual, the wrong tissue, or the wrong organ. diagnostic overexposure, where you're looking at the right part, but you're giving a greater dose than was intended. An equipment failure, where there's failure of the medical equipment or the software or the system with the potential to deliver an exposure substantially greater than intended. An interventional overexposure, again, one which is substantially greater than was intended, but with the potential this time to cause tissue reaction. And also an inadvertent exposure of the embryo or fetus. So a number of years ago, I carried out a study in a group of Scottish hospitals over a number of years. And so I'll show a few results as I go through the distributions that we found. So if we look at why or who is responsible for error, as one might expect, the majority of errors occur in the radiology department: the wrong patient, the wrong limb, the wrong side of the body, the wrong examination performed. There's lots of things that can go wrong in the department itself, but some of these can also be a result of an error in the referral. And so you can get all the similar errors to those in the above group, but also you might get repeat exposures where someone has requested the examination twice. It's appropriate, but they hadn't picked out that the examination had already been performed. For examples of diagnostic overexposures might be an AEC chamber that's not aligned with the X-ray tube, or digital image data which has been deleted before the images have been reviewed. Might be a CT scan performed without contrast media when contrast was required. Ones due to inappropriate settings or poor technique can be perhaps an incorrect exposure factor setting or inappropriate setting of the automatic tube current modulation. And there was a particular example of that, which I'll show a bit later. There might be an error in the CT scan start or scan position, so you're scanning the wrong bit of the body. It might be poor collimation in the pediatric exposure. Say, if you look at the image, one of the images on the right of a child, much more has been exposed than is necessary for the examination, including sensitive organs. And then poor positioning might be an X-ray tube close to the patient in fluoroscopy. So what should you do when an incident occurs? Well, you need to record information. You need to think about you need to think about the patient, and you need to think about the information that you need to record in order to carry out an investigation. So it might be the error codes or unusual signals, record those straight away. But also things that you need so that you can think about what the dose was or find out what the dose was. So for CT, this would be the CTDI, CT dose index. It would be the dose length product, and it could be the size specific dose estimate if that's also included in the display in new scanners. For radiography or fluoroscopy, it could be the Kerm area product, KV and MAS. And in interventional procedures, perhaps the cumulative air Kerma at the interventional reference point. So that's the radiation, the center of the beam at the distance reckoned to be that of the skin surface from the X-ray tube. And you might get this information from the DICOM in the radiation dose structured report. So what's the purpose of the investigation that you carry out then? First of all, it's to assess the consequences for the patient affected and provide any additional healthcare necessary. But then it's also to identify what went wrong, so you can implement changes to address any deficiencies and minimize the likelihood of this type of incident recurring again in the future. So that information then needs to be shared with others. So you need to share it with other staff, and probably the best way of doing that is through the general manager who can then disseminate it through the relevant safety committees. It needs to be done in a structured way so that the correct people are informed. But there's also might be a wider purpose depending on the severity of the accident. It might be to disseminate information about radiation incidents and radiation injuries in order to raise awareness and alert others with similar equipment that might have the same thing occur. So it may be helpful to appoint an individual to manage any in-depth investigation. So you've got somebody who takes on the responsibility for the investigation. They can get others to do things, but they are the overall responsibility and will prepare the report. Then they should obtain detailed information. They conduct face-to-face interviews with the staff involved. And it's important that you use a no blame approach. It's not the purpose in the investigation at this stage to point the finger. What you want to know is really sort out what happened and also identify any root causes and contributory factors. And then you need to consult a medical physics expert to obtain radiation dose information. But there may also be latent systematic errors within the department. So we often show this multi-layered Swiss cheese model where we have all these safety features in line which will stop most things, but in some cases it might go through all the holes and then we get the accident occurring. So it's the sort of thing like inadequate training of staff, poor knowledge of equipment and its features. There might be insufficient experience and so supervision of inexperienced staff. Perhaps a lack of optimization of protection for the patient. There could be flaws in the examination protocols which haven't been picked up. There might be ambiguities in the functions and lines of management. So an individual thinks somebody else might be responsible for doing something which can then lead on to an accident. There might be staff shortages or a high staff turnover so that there isn't time to give sufficient instruction to new staff. So there's lots of things that can go wrong, and you often get more than one thing contributing. So the outcomes in the investigation, we need to calculate or estimate the doses received, and this will be a job of the medical physics expert. Determine the corrective action to prevent a recurrence and produce a written report which states the causes of the incident. And then implement the appropriate corrective changes. So it's important to identify who's going to make those corrective actions. And then, if necessary, inform the referring medical practitioner and patient if appropriate. So what should go into the incident report? Well, you want to know what occurred, why did it happen? Did any deficiencies in the procedures or staff training contribute to the incident? The follow-up should look at remedial actions to see what improvements could be made to minimize the risk of similar incidents in the future. And the responsibility for addressing the deficiencies will then should lie, as I said, with the manager for the service. So on completion of the investigation, we want to debrief staff involved to explain the causes of the incident and then describe what adjustments have been made to the procedures. So some of the systems that can be put in place for preventing procedural errors might be having a pause and a check of critical items. So is it the correct patient? Has the question of pregnancy been addressed? Has the proper justification been carried out? Things like that. But if you stop and have a list and then you think of all those, then you can make sure that everything is in place. Then having, as I've said already, agreed procedures for investigation, defined responsibilities for taking action. And then after that, have meetings to follow up incidents and determine the causes. Might have periodic audits and review of procedures and protocols. And something which it's quite useful to ensure that when the X-ray engineers from the maintenance department take over a room to carry out maintenance, that everybody is aware that they then have the responsibility for radiation safety, and that's been formally handed over to them. I mentioned the errors in patient referrals, where you've got the wrong individual referred, but with a appropriate clinical history, or a request for the wrong examination. So it's not within the department. You've got to reach out to the referrer. So the system might involve the lead clinician sending a formal letter or email to the referrer and copies to the consultant or practice manager, but not just a passive thing. The letter should explain what happened, but then request a written explanation of why the error occurred and what actions been taken to minimize those risks in the future. Now, equipment faults require a slightly different approach. The faults in the X-ray equipment might give rise to, could very well give rise to more overexposures if you just left it in service. So the examples of the things that might occur are malfunction of the automatic exposure control, have been a software upgrade affecting the protocol and image processing. Could be something happening to the digital image data's lost, or some internal parameters have been set incorrectly after maintenance. So then the unit must be taken immediately out of clinical service until the issues have been addressed. And the investigation required input from the manufacturer's representative, as well as the hospital medical physicist and the imaging staff. So technical reports should be obtained from the equipment suppliers and tests carried out to verify that the equipment performance is satisfactory before the equipment's returned to service. And then, if appropriate, a report might be submitted to the National Incident and Reporting Centre, so that information about that sort of incident or faults can be disseminated to other users. And the systems to minimize equipment faults are the things that we should be doing routinely on all equipment: comprehensive acceptance testing, proper commissioning, adequate maintenance, have effective QA programs in place, have an equipment replacement program that ensures that the old equipment is replaced at the appropriate time. And it's also useful to have an equipment of sort of fault logbook. You can use the logbook to record any software and protocol changes, and have a system for checking the dose performance after software upgrades. So the incidents occurred, and there's various quantities that we can use for assessing dose: effective dose, organ dose, skin dose. So we need to choose the appropriate one. An effective dose is quite useful for small exposures, and the majority of diagnostic overexposures will be low. So for incidents resulting in effective doses less than a few millisieverts, generic values for the examinations from published data could be used if the dose is known to be similar to that from the examination. But the effective dose also can be derived from the data, the DLP in CT, or the Kermer area product in interventional, using conversion coefficients. And these results show the distribution of doses from the study of incidents that occurred in a group of hospitals over quite a few years. And you see that 48% of the incidents gave rise to an effective dose of less than 0.1 millisievert. But you'll see most of the doses, the higher doses, were actually from CT. So the most significant proportion, over 1 millisievert, were from CT. So what's the effect of these? Well, there may be a small increase in cancer risk, but for most of them, it will be relatively small. But if you start telling patients a sort of numerical value, it often sounds more scary than it actually is. So we actually, ICRP, recommend using general terminology linked to the dose level to describe that risk. And these are the terms that we've put in ICRP 147. So that's our publication on radiation protection dose quantities. So if it's less than 0.1, say it's negligible, 0.1 to 1 millisieverts, which for radiographs of abdomen, pelvis, etc., minimal. Between 1 and 10, which gets us into the sort of CT frame, we say they're usually very low. And between 10 and 100, which might be some CT scans, or it could be many CT scans. And there's more evidence coming up that individual patients do have or can have a whole series of CT or other examinations and build up effective doses above 100 millisieverts. So then we told the risk low. Above 100 millisieverts, we call it moderate, because it's trying to put the risk into general terms compared to other risks in society. So in assessing risks of stochastic effects, when the effective dose is more than 10 millisieverts, then we'd say a full evaluation using doses for individual organs may be appropriate, but that sort of dose level should be set by local agreement. And the quantitative risk derived from organ doses using age and sex-related coefficients are given in ICRP 147. They're also given in the report of the BEIR from 2006. The ICRP data is based on either a Euro-American or an Asian population. The BEIR is based on the American population, but we use very slightly different risk factors. So I would recommend for the present time using ICRP 147. And this gives organ doses or risk from the organ doses, but it also gives risks for particular types of CT examinations. So CT abdomen, CT pelvis, CT head. So you can calculate a better assessment of the risk for the patient of the particular age and sex that has been affected. So this assessment should be carried out by medical physicists, but the uncertainties will be quite large. I want briefly to talk about tissue reactions. The below 2 gray, so this is looking at doses to the skin, and below 2 gray, you shouldn't get significant, but between 2 and 5 gray, then you might get hair loss and recovery, but recovery will occur from the hair loss, and you might get transient erythema. And then above 5 gray, you can get much more serious which you can get from interventional procedures or repeated interventional procedures. But the extent of any tissue injury may not be apparent until many weeks later. So dosimetry information is the only indication of the potential for tissue reactions and the link to radiation exposure. It may not otherwise be recognized. And probably all been aware of the effect, the results for a clinic in the States, where there were a whole series of patients who had lost hair and erythema in bands around the head, because there's a certain examination looking at CT perfusion of the brain where you do a whole series of cuts on the same place. Skin reactions are rare. What happened in this case was that rather than selecting a high or not a fairly high noise index, the radiographer associated the low noise index thinking that was linked to a low dose, was in fact it's a low level of noise giving a high image quality. So it shows if you don't understand all the settings, just what can occur. So scanning patients multiple times because of this lack of awareness resulted in these effects. But you can also get the effects, it's been reported, a missing beam filter was dislodged. If there hadn't been a proper acceptance and testing system in place, then that would have given similar dose levels. So you can reduce these risks if you know what the dose is going to be beforehand. So the CTDI for the head is roughly equal to the skin dose. So the radiation dose check feature that is on many scanners can be used to alert the user before they carry out the scan of of whether there's going to be a risk of such effects. So you might set a dose check of 600 milligray or 1 gray for the CTDI. And these just show examples of poor practice with interventional work where the X-ray beam is being directed through the thick part of the body for a long period, or just one single sort of projections being used. And these have occurred in the 1990s, and there's it's important to bear these things in mind. So reduce the risk of deterministic effects in these. We should optimize the protocols during commissioning, but also perhaps review the patient information prior to the procedure to determine if they've already had significant doses, and check if they've had repeated doses, perhaps of 1 gray to 3 gray. And protocols should be available to take account of patient size, so using the appropriate levels for the appropriate size of patients. And there are now programs being developed which have plots of the skin dose distribution. So the factor that is important is the peak skin dose in determining whether there's going to be any effect. But for units that don't have this facility, the important thing to look out for is the cumulative air kerma at the interventional reference point, which simulates the skin dose really at the center of the X-ray beam, and get someone to monitor that during a procedure. And then set alert levels, so the interventionalist that should then be informed when the dose reaches an alert level, which might be a peak skin dose of 2 gray or a reference kerma of 3 gray, and have a trigger level. And if the doses go above that, then the patient's informed and they're followed up to check for any effects. So if the trigger level is exceeded, then perhaps they should be given an information sheet. They could be contacted and followed up to check they haven't observed, there haven't been any effects observed, and the patient's general practitioner and referring doctor should be informed of the exposure. And the IAEA have a system where events of this type above these sort of trigger levels can also be fed into a worldwide system, so that people can build up information on the type of incidents that do occur. And very briefly, unintended fetal exposures can give a small risk of cancer, which is about 3 times of that for the general population from the same dose. So potential causes are failure to identify someone's pregnant or an area equipment setup. And systems for preventing unintended fetal exposures, to have the notices in departments, and have agreed procedures for screening female patients involving confirmation of the date of the last menstrual period for the exam. But I know there's presentations on pregnancy later on in this series, so I'll not say more about that. So just to summarize, in order to reduce the risk of incidents and unintended exposures, to reduce the risk of cancer, have proper investigation procedures in place and educate staff in their use, set out responsibilities for notification, investigation and reporting in written policies, and make sure staff know how to respond if an incident does occur, and carry out an investigation to identify the causes, prepare a report and share the findings, and ensure that any changes and improvements required are made. And to reduce the risk of tissue reaction or incidents that might produce tissue reactions, ensure that staff operating equipment have received an in-depth training in use of the equipment and the dose reduction facilities. The check dose and other parameters can be used before CT scans. You can check what these levels are, and for interventional procedures, you can monitor the dose levels during the procedure, and set those check values to provide additional safeguards on the CT scanners. And I'll finish off with that just to say we had a technical meeting in the IAEA, and the reference in which we report that in the Journal of Radiological Protection is there. So thank you very much for your attention.
Thank you, Colin, for this outstanding presentation. I would kindly invite now the other speakers to turn the camera on and to start our panel discussion of Q&A. Well, first of all, I was right when I was saying that we would have a great session today with 3 great speakers, so thank you all. And before we go to the questions, then I would encourage all the participants to write down all the questions they have on mind for the speakers. I would provoke the 3 speakers with to interact between each other regarding each one presentation. I heard from Colin that he was impressed about the results of the EU Just CT. Any comment on those results, Colin?
It's not an area that I keep a good handle on, but I've not seen the sort of detailed analysis and reasons, and I think you need those sort of studies in order, because justification I always find quite a sort of I suppose being a physicist, it's quite difficult to get my handle exactly when things are justified, but apart from, you know, they must affect the management of the patient. But it's good because they're so difficult to get a handle on, then there's not all that many studies being carried out, and not any big studies. So I think it's big studies that you need, and I think that will be very useful. So I hope the ICRP know all about this. I'll tell them if they don't. I'm sure they do.
Well, this gives you the opportunity, because we have 2 radiologists here, to make a question about, okay, so these all the justification studies that are or have been made are looking at the justification after the requests have been made. And wouldn't Boris and Dimitris, wouldn't this be kind of a little bit biased, because obviously we are not present at the time of the prescription, so we don't know what normally is happening in this environment between, you know, the assistant doctor, family doctor, any kind of prescriber, and we are looking after the procedure is made. Any comment about this?
Yeah, if I may say, there were few studies, one in Northern Ireland and then one in Luxembourg, that basically was quite comprehensive, and Luxembourg is a small country, which was the basis for this larger study. And then they repeated the study this year after doing certain educational courses within Ministry of Health in Luxembourg, and they had much better results after 6 years. And then there was also one study in Sweden looking at these referrals using iGuide as standard, with practically similar results of more than 30% of inappropriate CTs. I think that there is no other way to look at appropriateness but retrospectively in this type of studies. If you would look prospectively, then it has to be done in a single institution, looking at particular environment of this single institution. Of course, that this would probably be more accurate because there are also phone consultations possible between referrers and radiologists. So if there are, but basically law requires that there are written procedures and that radiological practitioners approve examinations. So in order to analyze whether this was respected and whether this was appropriate, the retrospective analysis is the only way. There are some other things which we have seen, and in some countries where i-Guide is a lot in use, they did certain studies, for instance, where, for instance, the referrers require CT of chest, abdomen, and pelvis. And basically, by guidelines and clinical question, let's say only abdomen and pelvis are appropriate, but chest is not necessary. This was shown in some studies in Israel. Not a small proportion of patients have this type of examinations where they determined that also, even if part of exam is appropriate and the other part is not, it also adds to radiation exposure, and even they published some of these studies. So I think this is also interesting to look in the future and to design further studies. I have to say that our methodology will be repeated now, as far as I know, at least in one more European country, and the other one is interested to do it also.
Great, thank you. Dimitris, I checked that Slovenia is a very good, let's say, position. More than 80% of the exams certified. Since you are head of a department also, what do you think is the secret of this? Is it about education training, the system, the interaction between radiologists, radiographers, and other clinicians? What is your feeling about this?
Yeah, I think it's a bit of everything what you mentioned. I think it's very important to do promotion of these things to referral doctors, you know. And there I tried in Slovenia years ago to do it with IAIA, to educate them to the medical chamber. However, it was not, they did not want to include it. However, I think this should be a part of the training of referral physician during their period of renewal of their license. We tried to do it this way, however, it was quite difficult. Promotion, I think, here is very important, especially for referral doctors. And with this, I think you can really improve the results. Probably it's different from hospital to hospital. However, speaking with clinicians, having multidisciplinary meetings, talking as much as possible really reduces the level of unjustified examinations.
Yeah, what both of you, Boris and Dimitris, talked about the clinical decision support, especially the ones we have now in Europe, the i-Guide. Do you think it's a useful tool to improve justification, or do you think it would happen the same that happened in some American hospitals, where in fact in the beginning of the implementation of CDS, the number of unjustified, especially CT procedures, went down, but then after some years they went up again because the referrer learned how to bypass the system? What do you think about this CDS system?
Yeah, this is, sorry, I just let me briefly say, when we had this pilot project, we observed just this, that some nurses were bypassing the system. There were different ways of bypassing the system, but one of the ways to ensure uptake of this clinical decision support is that basically the examinations would not be reimbursed unless they were ordered through clinical decision support system. This is what in United States, Medicare was trying to do, but it also required, this was postponed from year to year. And this is one of the ways to ensure that referrers adhere to this. This is in reality a huge problem, I think. Yeah.
You know,
Dimitris?
I think the main point is education. We should educate them. And I was just a few months ago, I was talking to the chiefs of the department on a meeting that please, they should do it by doctors and doctors who know the patient, because it's the only way how to get good output from medical imaging.
Thanks so much. Before I go to Colin again, we have basically two questions from the audience, from Hilde Bosmans from Leuven. Thank you very much. One question is for Boris, another one is for Dimitris. Probably I will, since we have Dimitris on spot, has to do, and considering that the i-Violin is regarding oncological patient and especially oncological CT, what do you think should be the first point of action in the frame of abdominal thorax CT in oncological patients? What should be our first step in order to reduce those and improve image quality in these in oncological patients?
You know, I think we are talking about different things. First, we are talking about discovering something, so some basic, and then we are talking about the controls. I think in controls, there we should really reduce the extent of the imaging, because probably it's not necessary to image everything every time on a control, and probably we should re-examine the number of controls. You know, there are guidelines and CTs every 2, 3, 4 months. I'm not really sure that it's really necessary. It's a huge burden to radiology, but apart from that, it's not really important. I don't think it benefits really to all the patients. So there should be a real discussion. The problem is that the guidelines are mostly written with minimal or no influence by the radiological community. And that's why probably at the end we have huge amount of controls. I think we should focus on controls because that's very, very important.
Yeah, thank you, Dimitris. Boris, Boris, just a moment. I will give you the word because Hilde has a question for you as well that I would like you to make the bridge with what Dimitris said. Has to do with the lessons learned from the EU Just CT and what are the next steps. So please combine that answer.
Yes, I have seen this question. I wanted to answer, but what Dimitris said is totally right. And for instance, if some oncology guidance are in opposition to iGuide, I mean, iGuide are guidelines that were written by radiologists, subspecialties, and maybe what he says is really too much, or they require too often CT examinations. And then regarding Hilde's question, I think first, so this will be published in Radiation Protection Series, and data will be available in few months to everybody. The guidance document has been written. Steve Ebden-Jackson did a lot of work there, and all of us, and it was really, there was big input of advisory board and peer-reviewed group. This guidance document can be useful for particular departments who wants to use it, how to improve the justification procedures. I think that it could be useful. It's not too long, and it's really to the point. And we already have an example in Luxembourg where radiation protection authorities, seeing that they had very bad results in the first audit that was done in 2017 and published in 2019, they did some education of referrers, which is possible in a small country, and they improved considerably in only a few years with much less inappropriate examinations. I think that actually Belgian authorities, radiation protection authorities, are doing quite good job. I have to say Belgian auditors were really excellent, and I think that Belgian results are not bad. We have more problems in other countries, especially with this absence of clinical data or insufficient clinical data. So there are ways to improve. And for instance, this example of Luxembourg is very good.
Thank you, Boris. Now I have to pass to Colin, because I have two personal questions that came on the sequence of this year, ECR 2024, during several Eurosafe imaging sessions, especially with regulators starting to pass the message in the audience, which, to be honest, I think I would like to hear your opinion about that, for plain imaging, saying that don't worry about plain imaging. It's too low dose, no impact, no influence, so don't worry about that. So this is my first, and I'm quoting. In fact, it was in a session where I was chairing. Mm-hmm. And so this is the first point. How can we support the LNT model and then be going to a conference as a regulator and say something like that? I would like to hear your opinion about that. And the second question has to do with the tables you have shown, and those values also that both Boris and Dimitri shown. What, in your opinion, why are we dramatically increasing in technology in every field? So in plain imaging, CT, interventional, and why are we continuing to have patients with passing the trigger levels? What are we doing wrong here as a professional community?
Yeah, well, I'll come back to the second one, because I'm not entirely sure what you're asking that, but I think as far as the low dose radiography examinations and others, I mean, we would apply optimization for everything. I mean, you get your systems optimized, and then you repeat it on lots and lots of patients. So there's no point, if you don't bother about these sort of things, then you can give a substantially higher dose than you need to. But if you have the facilities, you obviously don't need to put quite as much effort into optimizing a chest X-ray as you do to a CT scan, because it's a lot. CT scan is a lot more complicated. But I mean, our report from the ICRP on optimization in general will cover all the different aspects. And we have chapters on radiography, fluoroscopy, and CT. So we cover everything, and we want to keep doses as low as possible. But what was the second one related to sort of interventional trigger levels?
To the interventional trigger levels, yeah, to the interventional trigger levels, and also for the fact that for plain and for CT imaging, we have a huge heterogeneity for the same procedure. You know, for the same type of patients, we have, you know, a huge heterogeneity in the dose, the procedure dose. Why is this still happening in the 21st century?
Because not everybody has received all the training and taking advantage of all the things that they should be taking advantage of. But I mean, whenever we do patient dose surveys, until relatively recently, we've always had this sort of high dose tail. But I mean, I think recent CT surveys in Scotland, say, we found that we're now getting to a level where we cutting off that high dose tail, and so we are changing. The dose distribution is actually changing for CT scans in some parts of the UK anyway. Okay, so apparently for the three speakers, the secret is education training, which in fact is in line with the scope of this work package 7 of Violin. We have one last question for a round for the three speakers. Is a question from Christoph A.
that says that ICRP 147 terms were discussed for communication of risk. It was also mentioned that these terms can help to communicate risk and not alert the patients too much. On the other hand, the risk should not sound too unimportant and thus irrelevant, especially for creating a sense of awareness in the follow-up of incidents. He asked for some thoughts on finding the right balance, which I think it's a very interesting question. And just even to provoke more, isn't it time to in terms of communication to shift a little bit more to the benefit than continue to talk about on the risk? I would like to hear your opinion on this. Let's start with Colin.
I mean, yeah, we've always got to emphasize the benefit. I mean, we try and use terms. I mean, they're terms that I've been using for some time, and we adopted those in the ICRP 147 because they're trying to put risk in context of all the other risks in society. The risks from our X-rays are low or negligible, or certainly the radiographs are negligible compared to most of the risks that we take in society through our lives. If we use stronger terms, then it's not giving the patient a sort of fair picture. But it is the benefit. I mean, I think most patients, I think in the UK, people don't refuse it. Very few people would refuse examinations because they're scared of the risk. But I think the situation in the States is perhaps a bit different, where there have been a number of papers written because of the lack of effort they put into optimization in the past.
Thank you, Dimitris.
Yeah, you know, I think if we achieve the right justification and if we have a good optimization, then this question is irrelevant, because then there is a cost benefit. If the patient needs something, it should be done. If the procedure is well optimized, then there is no risk, because the benefit of the examination prevails the risks many, many times. And it's not to scare the patients. Patients should know that they are in the safe hands. And that's what I think is the most important.
I can
let's close with Boris.
I can basically completely agree with Dimitri, but the justification process is crucial in this. We shouldn't scare patients, but on the other side, there are so many outlier cases in the practice that even we cannot call them outlier, because we have quite often, unfortunately, cases where young people in emergency service who are not well trained, or at the beginning of the training, send patients for extensive CTs, polytrauma protocol with 3 phases for very minor traumas. We see this quite often, and this is the problem of improper justification processes. If this would be solved, not patient may need CT of the brain, but not of thorax, abdomen, and pelvis. And this is important, and we need to follow this justification process, and we have to influence referrers to realize that in spite of the huge benefit that technology offers, CT, IR, there are still certain detriments, and that there is no need to expose patients unnecessarily, especially young patients. And I have to say, what we have seen in EU Just CT, it is much lower number of pediatric CT examinations. I hope that our listeners and you are aware of these 2 EPI-CT papers on children, that they might not, the risk might not be huge, but there is a certain risk. So we really need to make a good balance between risk and benefit, and do only examinations that are needed and appropriate.
Brilliant. Thank you so much. We need to close this webinar. It was really, really an honor and a privilege being with you this, well, evening, morning, or late night, depending where people are listening to us. I think there are three main words or not words, but concepts around this is first, the exam must be justified. If justified, it has to be optimized. If they are justified and optimized, the risk is obviously not a point of discussion, because what is a concept here is the benefit is higher than the risk, because the exam is justified and optimized. And for me, the most important thing is that all of this is only possible with education and training. Thank you so much, Boris, Dimitris, Colin. It was a real privilege.
Thank you.
Thank you for joining us. And I will encourage all our participants to join us next week for the second webinar of this i-Violin project. Thank you very much.
Thank you.
Bye.